So how did we get to where we are today? Look, as a preface, I note that people with mental issues, including gender dysphoria, must be provided with empathy and strictest professional and respectful care. It is clear that nearly all parents love their children and desire to support them whether they agree or disagree with their transitioning. Similarly, health professionals seek to provide the best care, whether adhering to the affirmative model or the traditional explorative model. While we should strive to treat each other with respect and kindness at all times, it is also vital to seek the truth. We need to debate life-altering models of care for gender dysphoric children and teens openly. As Thomas Sowell implies, truth is more important than kindness, because truth is kinder in the long run. Despite strident efforts to depathologise gender dysphoria, it remains a psychiatric diagnosis in the Diagnostic and Statistical Manual of Mental Disorders. I teach the subject of psychiatric diagnosis in the psychiatry training course. I have taught developmental psychology that provides further context for defining psychiatric disorder. The gender dysphoria debate has to be seen through the wider lens of historical psychiatric diagnosis controversies, so I'll address these first. Here are 3 slides from my lecture. As far back as Hippocrates, it was recommended to consider the full context of a patient's life, not just focus on the main symptoms. The biopsychosocial model, where factors are looked at from predisposing to precipitating to perpetuating and prognostic and protective, and not just the pattern of symptoms, is the basis for comprehensive psychiatric diagnosis. And I end the lecture with this pithy quote from a famous American psychiatrist. As covered in the lecture, overdiagnosis and misdiagnosis epidemics and individual case errors occur when we stray from applying the biopsychosociocultural model, and a form of reductionism intervenes, be that biomedical reductionism that ignores psychosocial and cultural factors, or psychological or social reductionism ignoring biomedical causes, or just informational reductionism, taking a fast, superficial history, looking for symptoms in a checklist style without consideration of the overall context of the patient's life. Diagnostic controversies and overdiagnosis epidemics in psychiatry are as old as the field itself. My doctoral research investigated the 2-decade overdiagnosis epidemic of bipolar disorder in very young children in the United States, and titled Pediatric Bipolar Disorder, Why Did It Occur? The Iatrogenic Consequences and Implications for Psychiatric Nosology. Nosology being the classification of diagnoses. A slight silver lining to this epidemic is that bipolar disorder was often diagnosed late. The epidemic of overdiagnosis did make us more vigilant for early signs of onset. However, this is dwarfed by the iatrogenic, which means harms caused by medical interventions, consequences of 25 years of over 1 million children and teens misdiagnosed and over-medicated, and according to peer-reviewed and FDA pharmacovigilance data, possibly several thousand deaths, mostly via cardiac conduction problems from high doses of psychiatric drugs, such as 4-year-old Rebecca Riley, diagnosed with ADHD at 28 months and paediatric bipolar by age 3. But also parents, teachers and children and young people themselves identifying with an illness the vast majority did not have, and therefore other causes of their emotional and behavioural problems were neglected. Many may go through decades or their entire lives erroneously believing they are, quote, bipolar. As subpoenaed internal pharmaceutical company documents released from criminal cases proved, there was commercial influences were behind the bipolar epidemic. Big pharma funding of biomedical reductionist psychiatry departments drove paediatric bipolar research and clinical guidelines, along with a biomedical ideology and the desire of both parents and prescribing clinicians for a simple answer and medical fix for dealing with messy, multifactorial childhood behaviour problems. Another aspect is the capacity for groupthink, or what Rhodes and Thomas in a recent Spectator Australia article term crowdthink, whereby our species undergoes mass hypnosis by a new narrative. It takes courage to seek and speak truth when all around you are in the grip of a narrative. A basic tenet of psychiatric diagnosis is don't jump to conclusions. Psychiatry requires longer sessions and usually several to conduct a full assessment and involves listening to family, teachers and other relevant persons for collateral history. This was bypassed with the paediatric bipolar epidemic. The author of this book, The Intelligent Clinician's Guide to the DSM-5, favourably reviewed by Sydney psychiatrist Professor Gordon Parker, is Professor Joel Paris, the former chief editor of the Canadian Journal of Psychiatry, who 10 years ago said, 50 years from now, paediatric bipolar will be seen as the greatest scandal to befall psychiatry. It can take time for an overdiagnosis epidemic to be fully acknowledged. Gender dysphoria, formerly gender identity disorder, is a cluster of symptoms or characteristics that has been studied for decades. At the individual level, someone, particularly a minor with gender dysphoria, being uncomfortable with their observable birth sex as male or female, leaving aside intersex cases, needs a multi-session assessment and discussions with parents, and the information be filtered through the biopsychosocial intersecting with time-dependent factors grid for a deeper understanding of why they feel this way. Prior to the last 15 years, that is what the few gender clinics for the rare gender dysphoria cases did. Often a good biopsychosocial diagnostic formulation fed back to the person in appropriate language that grants deeper understanding of themselves and their symptoms is therapeutic in itself. It sometimes causes symptoms to abate. It allows the therapeutic journey to begin. With regards to gender dysphoria and busy child and adolescent work involving supervisory oversight of community teams, inpatient units and emergency departments since 1995, I don't recall ever seeing a single female-to-male gender dysphoric patient until the late 20-teens. There was less than one handful of very effeminate boys who seemed they might be more comfortable as females, but probably were on track to being effeminate gay men and quite likely happy, particularly as modern society was far less homophobic. What was strange was the inexorable rise in gender dysphoria cases since about 2017, the vast majority typically 13 to 15-year-old biological females not wanting to grow up into women. Sex is binary at the cellular level, which is why lifelong hormones are required to maintain a transgender physiology. Increasingly, these young teens with 2X chromosomes would describe themselves as theys, non-binaries, though often that was a stepping stone to wishing to transition to trans males. From none in 2 decades to a trickle for 5 years and a deluge in the past 5 years. A couple of years ago, when working a week's locum on a 6-bed adolescent mental health unit, there were 7 14, 15-year-old biological female patients over the course of the week, of whom 5 identified as non-binary or male. So, in the Western world, we're dealing with a gender dysphoria epidemic. My doctoral research and teaching the topic of nosology has made me aware of diagnostic epidemics. Interestingly, there's sometimes a kernel of truth in the epidemic. For a quick run-through of some. Coro, also known as genital retraction syndrome, an anxiety syndrome where men believe their penises are retracting into their abdomens or women believe their breasts are shrinking. It occurs in epidemic mass hysteria outbreaks in Southeast Asia, India, and Africa. Mass hysteria of agitated people with anxiety-related symptoms and associated autonomic nervous system dysregulation based on increased focus on their bodily symptoms in a vicious cycle, and seeing others with the same, have occurred throughout history. The medieval dancing manias, where mostly young women would dance till they dropped or even died, being an archetypal example. Sometimes this manifested as contagious laughing epidemics, as infected nunneries in past centuries and Tanzanian schools in 1962, or an outbreak of factitious Tourette's disorder in a New York school in 2011. In socially repressive Victorian times, hysteria, which since ancient Greek medicine had been associated with the uterus, was a way for mostly young women to express distress they couldn't otherwise ventilate. Hypnosis and Freudian psychoanalysis began as cures for hysteria, Freud initially postulating histories of sexual abuse as the cause. In Germany, women had their ovaries removed to treat hysteria, or what we'd call dissociative disorders today, until psychiatry and psychoanalysis identified psychosocial causation. On the other hand, a small proportion may have been suffering late luteal phase dysphoric disorder, which in its very severe form is very rare, but an oophorectomy would treat. The 1949 Nobel Prize in Medicine went to a Portuguese neurologist for pioneering lobotomies. These pacified some patients with severe schizophrenia and became popular from the mid-40s to the mid-50s, with tens of thousands performed, including on children and also on some homosexual men, to render them, quote, morally sane, end quote. But at the same time, Soviet psychiatrists... Oops, sorry, I won't go back a sec. There was more there. These days, tiny targeted leucotomies can reduce severe OCD, but frontal lobotomies were obscene malpractice and recognised by many psychiatrists and neurologists as such at the time, The dissenters noted a groupthink mania took hold of the medical profession and society during the height of the lobotomy epidemic. Soviet psychiatrists led the way, banning lobotomies, saying it just, quote, changed an insane person into an idiot, end quote. But at the same time, Soviet psychiatrists during Stalinism were diagnosing, incarcerating and medicating thousands for, quote, anti-Soviet thought, end quote, and non-atheist religious beliefs as having, quote, sluggish schizophrenia. Australia had an epidemic of RSI, repetition strain injury, in the 1980s with the advent of increased keyboard usage. The occasional person still gets tenosynovitis from typing, but it's no longer an epidemic threatening to bankrupt work cover. Most nations missed the social contagion of RSI. It seems the positive reinforcement of work cover payments may have been a perpetuating factor. I recall the satanic panic of the 1980s. Supposedly numerous daycare centres performed satanic ritual abuse on children. Despite cases of paedophilia, as we know from the Royal Commission into Institutional Child Abuse being more common than society likes to admit, the satanic panic was social contagion, and quite a number of childcare workers were wrongfully incarcerated. The 1990s multiple personality disorder epidemic followed. Thousands of cases occurred as therapists explored interactions with their clients' various alters, fostering increased identification with being a multiple. When the professions realised they were perpetuating cases via affirmative treatment and precipitating the creation of new cases as the public was influenced by both the media and psychology literature, the epidemic faded. Today, genuine dissociative identity disorder cases exist, but are again rare. Psychoanalytic therapies and models such as internal family systems therapy seek integration of our various, quote, parts, rather than affirming autonomy for those parts. We have an ADHD epidemic. The concentration-enhancing benefits of psychostimulants implies that a large number of us have ADHD, but it's not that simple, a discussion for another day. The autism spectrum epidemic directly relates to gender dysphoria. Diagnoses of ASD overwhelm the NDIS. The situation is nuanced. Cases missed in the past now recognised, pollutants and chemicals affecting fetal infant brain development, increased survival of prem babies, older parents with older sperm eggs, changes to microbiome from glyphosate in the food chain are among hypothesised causes of real increase. But the educational and financial incentives drive ASD diagnoses, and some are simply introverted temperaments and a bit obsessional or quirky. Where the line is drawn becomes subjective. Teenage girls on the ASD spectrum, or just shy and quirky, comprise many of those presenting to gender clinics. In the 90s to the early 2000s, as a child psychiatrist, these shy or ASD girls and some boys would more likely present as emo. It was a big movement, goth light, with histrionic misery replacing goth's histrionic aggro. Those identifying as emo usually had anxiety, depression or eating disorder symptomatology, and as the predisposing, precipitating, perpetuating factors for these comorbid problems were addressed by a usual mental health practice, the urge to be emo often faded. How many in their 30s or 40s today remain emo? I recall as a father being taken aback at the rapid onset emo identification that occurred with one of my daughter's social groups. Early adolescence is, as the famous developmental psychologist Derek Erickson noted, a tumultuous time of ego identity, confusion and fluidity. It is not unsurprising that rapid onset gender dysphoria particularly affects pubertal girls, as shown in Littman's peer-reviewed paper. As Professor Diana Kenny summarises in her well-researched book, much research shows peak susceptibility to social contagion occurs with 14-year-old girls, though any astute parent, teacher or clinician is well aware of this without needing peer-reviewed studies. Professor Kenny cites DSM-4 in 1994, stating that 5 times as many boys as girls were referred to paediatric gender clinics, but by 2020, the Tavistock GIDS showed a massive inversion to pubertal girls dominating referrals. Pre-affirmative care, there were child and youth gender clinics for rare cases of gender identity disorder. This is Professor Zucker of University of Toronto, chair of the DSM Committee on Gender Identity Disorder, subsequently sacked from his tenured position for not converting to a gender affirmative model. Professor Levine, Professor Koski and Dr. Hakeem and many others were leaders in the field prior to when the so-termed Dutch protocol became adopted beyond its initially narrow spectrum of male to female cases. And this coincided with increasingly liberal standards of care by WPATH, originally called the Harry Benjamin International Gender Dysphoria Association, in honour of endocrinologist sexologist Dr. Benjamin, an associate of influential sexologist Alfred Kinsey. Dr. Benjamin treated rare 1950s transsexual cases and advocated medical and surgical transition rather than explorative psychotherapy. Nonetheless, the original child and youth gender clinics found high rates of desistance during normal puberty. There was also a lack of the positive reinforcers seen in current LGBTQIA+ perspectives incorporated into schools, jobs and societies. Zucker cited a desistance rate of 88% and persistence to transgender rate of 12%, and that was with a small fraction of today's referral numbers. With the explorative approach, there was not just one trans phenomenon, but multiple causes and differing subtypes of gender dysphoria, elucidated by applying the norms of psychiatric diagnosis within a biopsychosocial model of care, and include disordered attachment histories and enmeshment with parents, child sexual abuse and effects on gender identity or phobia of being vulnerable as a woman, internalised homophobia against male homosexual or lesbian sexual orientation, having feminine interests as a boy, masculine interests as a girl, phobia of growing up to be a victim of domestic violence, transvestism, fetishes, and autogynephilia, which is the sexual arousal of a heterosexual male for fantasising or acquiring a female body. But in recent years, a bill with almost identical wording was introduced into many Western legislatures, prohibiting health practitioners from too diligent exploration via biopsychosocial assessment. Rather, it should be affirmation or possibly lose your licence, even go to jail. The international coordination of that bill is interesting. In fact, according to investigative journalism by Jennifer Bilek and others, it seems the trans rights movement is global and extremely well funded. Hormones cost over $1 million for life, let alone the cost of surgery. And analogous to the bipolar disorder false diagnosis epidemic fueled by millions of big pharma marketing, research grants, sponsored patient advocacy groups, the trans activist movement, according to Bilek, receives many millions in financing from billionaires invested in the medical industry. Bilek names adult trans women billionaires Jennifer, previously James Pritzker, and Martine Rothblatt for donating significant sums. And Rothblatt, a lawyer by training, authored the very first of the anti-conversion therapy bills, legislative bills. Bilek also cites Rothblatt as extolling the transgender agenda as a path towards a transhumanist agenda. Bilek says, to quote, "Reproductive sex is being deconstructed for the market. Eggs, cervixes, hormones, breast, wombs, etc. It's why women are being referred to with terms like chest feeders, birthing bodies, cervix habits, etc." Now, this sounds perhaps outlandish, but a few years ago, when I had barely heard of transhumanism, I spoke to a former executive of one of our major political parties, who told me that this was a very wealthy, influential international political lobby group. It'd be interesting if any of the MPs here have heard of this. What Bilek's research suggests, though, is that given funding and international coordination, the sudden rise of gender dysphoria is not simply a grassroots phenomenon. Perhaps overshadowing that funding is the US foreign aid being tied to promoting trans activist agendas, as per recent audits of USAID and celebrated in this 2014 post on the White House blog. Also as described here, the social science of queer studies arose from activism, which may be finding social truths, but then again is predicated on assumptions consistent with activist goals, rather than completely open-minded scientific exploration. Such assumptions are epistemologically more akin to theological studies in a particular religion, rather than to true social science. In terms of our biological-driven psychology, we are an animal species like any other that responds to positive reinforcement cues, especially to be in harmony with herd, tribe, group narrative. One of those reinforcers is the reported millions flowing from the billionaires. Another, the social media likes, shares that feed social contagion. Another is the new educational curricula teaching primary schoolers about a multiplicity of genders. And another, the gender affirmative care model that could well be retitled the positive reinforcement model of care. And it minimises the level of questioning for underlying origins of symptoms which we would professionally practice for any other psychiatric disorder. The only rational ethical reasons to drop this exploration is the assertion that gender dysphoria is absolutely equivalent to sexual orientation, and the rightful depathologizing of homosexuality, lesbianism and bisexuality over the past half-century now needs to be applied to gender dysphoria. But that is an assertion without firm evidence, and several detransitioners say their same-sex orientation was buried by the rushed transition. Prescribed disruption of normal sex hormones and permanent surgeries in young developing bodies is deemed ethical on the basis of an unproven assertion. It is true that feminine and masculine traits vary across the spectrum, Effeminate boys, tomboy girls always existed. Many grew up to be gay and lesbian, which thankfully is easier today. Society was increasingly encouraging of men's feminine side and women's masculine side, but now the trans option is readily available. For some, it may be the best path, but for gender-confused youth, there's so many positive reinforcers along that path and very few breaks in 2025 here in Australia. Given the gender affirmation model deficiencies, the rise of detransitioners is unsurprising. I've met a couple and listened to over a dozen on YouTube. They ask, with eloquence crafted from deep introspection and fierce emotion, why were they not offered a full biopsychosocial explorative model of care? Because usually in their 20s, with greater capacity for abstract reasoning as well as life experience, they've realised their gender dysphoria was due to other factors, unaddressed by gender transition. They describe intense grief over lost normal adolescence and of biological sex capacities such as orgasm, fertility, or ability to breastfeed. Some say they hear from many others who are still in the detrans closet, or whose social and emotional sunk cost in their transition means remaining as regret cases, making the best of their transition bodies. Short-term published outcome studies by WPATH-compliant gender clinics describe tiny regret rates, but have high non-response rates, and would not capture what the detransitioners say is commonly a 5 to 10 year journey. The UK CAS review criticised the outcome studies as methodologically weak and noted that British adult gender clinics refused to give access to follow-up data on the Tavistock paediatric cases. Detransition regret cases would be far fewer with a return to a traditional explorative model and a public and school education campaign about the wider range of factors that can create gender confusion, particularly in early puberty. The UK, Scandinavia, and now the USA are heading in that way, and in Queensland, a pause and review is occurring. Regret cases are more likely, as last month, a large outcome study post-gender affirming surgery showed significant worsening of depression, anxiety and suicidal ideation post-surgery. I have two anecdotes. Firstly, I and child psychiatrist colleague Carrie Brakey presented with the AMA state president to a Queensland parliamentary committee about the anti-conversion therapy bill. I argued that hypothetically 2 14-year-old girls come into my clinic one after the other, each saying the same thing: they're morbidly obese, want anorectic drugs, followed by gastric sleeve surgery. The first chews lollies, has a BMI of 41, is pre-diabetic. I refer to an obesity clinic. The second is skeletal, about to die of starvation, so I admit her to hospital for forced refeeding under the Mental Health Act for anorexia. I went on to say, yet your bill in Parliament doesn't want me to make similar assessments of underlying causes for gender dysphoric teens. Now, the parliamentarians seemed impressed by this analogy. We got a slight amendment to the bill that makes us feel slightly safer as therapists. In the couple of weeks after our submission, 10 of my child psychiatrist colleagues in Queensland went out of their way to thank me. Some said they were glad that a couple of us had the courage to speak up. Second, I saw a mother with her anxiety-suffering biological daughter who was identifying as male and receiving gender-affirmative care. The mother was trying hard to use the preferred male name and pronouns for her now transitioning son. However, questioning revealed intergenerational domestic violence in a misogynistic, patriarchal family culture and several male relatives incarcerated, including for murder. The mother had in fact fled with her 2 daughters and some of her sons to our region. Speaking with mother alone, she said her sons were abusive to her, typical of their misogynist social modelling. Realising she could express her feelings, she became teary and she said, quote, and because it stuck in my mind, I used to have my 2 girls who I could relate to as a woman. I've lost the older one, who is now a son, but has become aggressive like all males in our family. Now I'm going to lose my last remaining daughter. And she cried. There's so much to unpack in that case, but the obvious is, why would you want to grow up to be a woman and victim of a domestically violent family culture? The current positive reinforcement situation provides parallels, as I see it, to 1990s multiple personality disorder or diagnosing thousands of preschoolers with bipolar disorder in the USA, something Professor Parry, the editor of the Canadian Journal of Psychiatry, said one day would be seen to be the greatest scandal to befall psychiatry. Whether the gender affirmative care model is later seen as a rival scandal, we shall find out in the coming years. Thank you.